This video I thought about after someone said, how many sutures are you going to put in me, or how many stitches are you going to put in? Because this is a classic question people always ask, you know, and in the lay person's mind, when they ask this question, they're thinking how long is an incision, or how big or complicated the procedure is. And I thought about it. I said, this is, it's very confusing. For example, if I'm doing a 20 centimeter incision for a hair transplant on the back using a strip method, I'll be using one suture, only one layer. And that's a whole discussion of why I don't do multi-layers. I find very good healing with one layer. I don't like multi-layers. Whereas when I'm doing an incision on the face, I'll do 5 layers. And on a facelift, I'll do 1. And on a nose, I'll do 1. And in a tiny distance about this short on a nose, I will put in maybe 30 sutures into a space of about, 1 centimeter. You say, well, are you inconsistent, Dr. Lamb? What are you doing? So first of all, the answer to the question is irrelevant, because obviously what I've just explained to you is that I do different things for different areas, and there's a reason. But as you guys are inquiring minds, you probably want to know, why do I do different things? Why is one layer 5 layers, and why is something else 1 layer, and why are things 2 layers? What are the techniques different? What are you doing differently? So I'm going to break it down and explain each of the areas of the head and sort of explain to you why I do different layers and what are the purposes. So, and I'm not going to go into too much detail because I can probably spend half an hour on each single thing, but you want to get a good overview of all these elements. And then for the 5-layer closures, I'll detail sort of why I'm doing a multi-layer closure on these and when do I do it. So with a hair transplant, just briefly, I have found that if you close an incision with very minimal transection, which means I don't hurt the hairs, and I use a lot of tumescence, which protects the nerve and blood supply, and I close it with what's called a trichophytic incision, which means I let the hairs grow through the incision. A single layer closed a little bit more tightly. Then I close these with almost no pull on the skin, but back here I actually close just a little more tightly because of the tumescence fluid relaxes. I want it to actually relax to a flat level, so I close with a little bit more tension. If I do all of that and I leave a suture in longer for about 3 weeks, but use a removable one, I find that the incisions heal almost invisibly. When I use multi-layers on the hair transplant incision, the deeper stitch would strangulate the hair follicles, would also cause irritation to the deep follicles, and then sometimes cause a widening of the scar, which is counterintuitive because you want to take the tension off the superficial skin. That's why people close in multi-layers. But I find to be the opposite case, is that with hair transplants, a single layer closure is the best. So I will actually let's talk about all my single layer closures and why do I do single layer closures, because the standard people think about is needing 2 layers. So let's talk about a rhinoplasty. So in a rhinoplasty, in about 85% of the time, I'm closing it with a single layer. First of all, I find that you just simply don't need 2 layers. It heals better. Now, what is the negative of using a deep suture? So the negative of doing a deep suture is that that suture may want to spit out and then cause a little bit of widening in that area. So you want to be very careful with that. I do use a second layer here when there is some tension on the incision. Then I will put that one stitch with the knot cut very closely, just to take tension. If I've projected the nose out, there's a little bit of tension on the incision, I'll put 1 deep stitch in, but I don't put more than 1. And then for the nasal sill reduction, which is this area, I will put 1 stitch in there because I find, because I'm now taking a wedge of skin away, there is a baseline tension to the wound. I have to close a deep stitch because there can be tension. Anytime there's a potential of tension on a wound for the nose, I'm putting a deep suture. When there is no tension and it closes perfectly, especially between here, it's a single layer closure. So do you understand this? In the old days, I used to use a removable stitch, and I find that the removable stitch here actually healed not as well, and I'll explain to you why. And also, it was very uncomfortable to remove this stitch because they had to be all these interrupted stitches. In other words, single stitches, so they didn't heal that well. I'm sorry, that was very uncomfortable when I took it out. And because it was uncomfortable, I could only put about 5 or 6 stitches in because I didn't want someone to have a lot of discomfort during the removal. I learned this in 2015 when I was lecturing in Russia, and I found that the Europeans use a dissolvable stitch. The dissolvable stitch takes about a month, but it's the color of the skin. The reason I like dissolvable stitches, one is that it holds the epidermal layer together longer, which is necessary to minimize any stretch back, especially if I'm doing a single layer. And I'm able to finesse it. So because my incision is a V-shaped incision, I'm able to go in there and make a lot of fine adjustments to the incision. So if something is not perfectly aligned, I can go back, put another stitch in. I can put 30 stitches in a matter of this short a distance to make sure the wound is perfectly aligned. And the reason why this is more complicated, why it takes more stitches, is that it's an inverted V, and then it goes inside the edge of the nose, and so it's complicated, and everything has got to be perfectly aligned. And that is another discussion, which maybe I'll include in this, is sort of basic plastic surgery techniques in terms of how I close something. But suffice it to say that I find that dissolvable stitches heal better in this area, and I put a lot of them in. The upper eyelid, for a while I used dissolvable stitches, and I found that in the upper eyelid was a very unique problem. It caused little bumpiness in the skin. Now I easily fixed it by putting a little cautery, but no one wants to do that. So I find that in the upper eyelid, a single layer closure with a removable stitch at a week heals the best. So each thing has this different way of doing things. In the facelift, on the back of the ear, I use a single layer closure. Front of the ear, single layer closure, and the back of the ear, I use a chromic that lasts 2 or 3 weeks. I had a patient come from Oklahoma that was from another doctor's facelift, and he put staples in. I said, oh, this is going to be a problem, but I went ahead and took out the stitches at a week, and the wound fell apart. I had to close it back up. This was not my patient. But this is why for 20 years I've always used a dissolvable stitch behind the ear, because the outside of the face areas take longer to heal. Now, there's a natural question is, why don't you do a multi-layer closure on the facelift? You simply don't need it. As I told you, a deep stitch that it has a tendency to want to spit out and can cause an issue. I don't like to put a deep stitch if there's no tension, and so when I do a facelift, there's no tension on the wound, because I've taken all the tension on the deep tissue. So when it's perfect overlap and there's no tension, I don't do a multi-layer closure. Now, if there's any tension because I've had to take a scar out from someone else's, I'll do a multi-layer closure to relieve that tension. But it's never good to put tension on a facelift incision if you can absolutely avoid it, because that's what leads to a widened scar. My scars heal great. This is why I close in one layer. You simply don't need that second layer in my hands because it heals so wonderful. And I do what's called a trichophytic incision here, just like in the back of the head, allowing the hairs to grow through the scar to make it heal better. So where do okay, underneath the neck, there can be some tension, and this area doesn't heal quite as well as the sides, so I do a 2-layer closure on this one to take tension off. A lip lift is a 3-layer closure, and the 3-layer closure. So what I'm doing here is that because skin is being removed and there's tension, I've got to put a deep stitch, multiple deep stitches, so that there's no relaxation on the tension. And I find that these stitches here heal better if I remove them. Sometimes they heal better when they're in, sometimes they heal better when they're removed. These heal better when I have sutures that I remove at a week. These heal better when I leave them in. So each thing has a different technique, and this is sort of understanding why I do each of the things. And the reason I do a 3-layer closure is the first closure is taking tension off, is the deep dissolvable stitch that I'm using to hold tension off. And then the skin is approximate with a tiny removable stitch that's running straight across, a single layer across there. And then I do what's called a horizontal mattress. And so what I find that this area to heal the best is when I can bunch the skin a little bit like a tent. So it looks slightly tented at a week, and then it flattens out. And that makes this area heal much better. I like how that mattress works in this area. Now, when I do a lip advancement on the bottom lip, that's a single layer closure. When I do lip reduction, single layer dissolvable stitch. When I do a corner of a lip lift, I do a 2-layer removable stitch. Now, I guess I'm confusing maybe the fact that I'm doing all different stitches, but each area has a specific reason for why I'm doing what I'm doing. Now, I'll finish with the most complicated closure, which is a mole removal, which is very confusing because you think, well, the mole has got to be the easiest thing. You just cut a mole out and close it. And to be honest with you, the mole is the most complicated, and I'll tell you why. First, the mole removal is an incision in the middle of the face or somewhere where there should not be an incision. Facelift here are very well hidden. You don't see them. They typically heal very well, and that's part of the reason you don't need all these multi-layer closures on these areas. Plus, they're an area that just simply doesn't need it. But when you make an incision in the middle of the face, this is an area that really needs astute multi-level closures to make sure things heal well. So first, because a mole is removed, you need to do a deep stitch. So that's a deep dissolvable stitch. Remember what I'm saying, the more that I put in, the more risk of spitting out. Like on the lip lift, because it's a length of an incision, I've got to put multiple ones out. So I tell all my patients with a lip lift, be prepared to feel a little stitch pop out or see a little stitch, but that stitch is clear and really small. So usually it's only when you're under magnification do you see that. I just say don't trim it because it's going to dissolve in a couple of months. Let it dissolve, don't trim or cut it. But this is the one I've got to put more deep stitches on. Where if it's a long mole or something, of course I'm doing more, but usually moles are short, so I'm trying to put as few as I can in there so that they don't spit out. And again, spitting out doesn't mean there's a big lump out there. It's just a small clear one that you may see on a close range. Then I close with, and each progressive layer is trying to adjust the incision both in terms of height and also length, so that everything is, it's a layer by layer getting closer to perfection. So I use a second layer to interrupt it just to make sure all the angle, everything is put perfectly. Then I put a running across there, and then finally I do a horizontal mattress. And the reason is that mattress is a suture that goes here, 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 here to evert the edges, because in the past when I didn't do this, I found that the incision would drop a little bit and cause a little hole, which I can fix, but of course I don't want to fix it. So in middle of face elsewhere, I typically do a little bit of a mattress incision, and that's very similar to a scar revision. With a scar revision, I'm also doing multi-layer. Scar revision, the classic one that I do is a geometric broken line repair, where I'm approximating the incision in multi-layers and then making sure every little triangle or square or all those edges are perfectly aligned, and that takes even more work than a mole in terms of alignment, and takes sometimes 3, 5, 6 layers to make sure everything is perfectly aligned. So that's even more visual work, all done under magnification. I use a 2.5 magnification to do this. Just did an FUE procedure this morning, and I'm doing a 8.5 to harvest with that. But when I'm doing a standard operative work is usually 2.5, 2.7x is what I need to do the work with. I think it may be fun to talk a little bit about plastic surgical techniques for those that don't understand this. This is hopefully not too long a video, but there's a joke in the world of plastic surgeons, which is the definition of plastic surgery is just surgery done right, which is basically, what that basically means is that we always joked in the facial plastic world is that the neurosurgeons, which is funny because they're brain surgeons, usually made the worst incisions because they just took out a tumor. They're more focused on getting that tumor out than how it looks when it's cut. But the few things in terms of closure in terms of technique, one is you want no tension, as I mentioned. You want to put deep sutures to take tension off, and you also want them, if you can, make incisions along what's called relaxed skin tension lines. You will do so, which is along how natural collagen bundles follow, so there's less tension on the wound and it follows the natural pattern. You want to make cuts on what are called subunits, if at all possible. So subunits are basically where your brain naturally sees a line. So for example, on nose, I recently did a mole. I did a video of this where what I did was I tried to follow where the mole incision fell. I tried to follow where a natural crease was, so your brain has a hard time seeing that line. If you make a line where a line shouldn't be, like a mole in the middle of the face, your eye will dart to it, especially if you're looking at a very young person. So you got to make everything in a way that's well hidden, where natural lines sit. It's like on a facelift. You listen to my video on facelift incisions. I'm not going to go into detail, but it's all hidden in curvilinear lines. And so the more linear your line is, the more visible it is. And that's the principle of scar vision, is to make a line hard to read, is to follow these areas. So no tension, relaxed skin tension lines. Try to make it all flow perfectly. And you want to try to avoid what are called dog ears. And dog ears are when one side bunches up on the other. In our fancy world, we call it a standing cutaneous deformity. And so what I do for that, and the way you minimize a dog ear, for example, the classic area is the back of the ear, sorry, the back of the hairline where I'm doing a facelift, is that the incision's got to be long enough not to create major bunching, and I do a rotation of the flap so that that flap doesn't become bunchy. But the other trick is that if you've got one side that is longer than the other side, as you're taking stitches, you take a stitch bigger, advance farther along on the longer side so that they can align slowly. So they picture a much longer incision and a shorter incision. That's oftentimes the way it occurs on the back of the ear. Instead of taking that incision longer to try to chase that dog ear down, I already know that this is shorter and this is longer, so I prepare for that. As I close it, I take slightly longer bites all the way down until they're perfectly aligned. The same goes true with depth. If one incision is a little deeper than the other, so if one is deeper, I'll take a bigger bite on the deeper one to pull this one up, and a smaller bite on this one so that they level up. And that's the other reason why I do multi-level closures, so that as I proceed, each layer is correcting it more and more. So let's say the deep layer corrected it this much. The next layer corrects it this much. The next layer corrects this, so that's the reason why I'm doing progressive layer closures in the cases that I need to do that. I don't always need to do that. And as I said, just throwing sutures for the sake of sutures is not a good idea because of the risk of spitting. You don't need more foreign bodies. The other principle is that I don't use any permanent stitches that are in the body except for otoplasty. I find that with otoplasty, I've got to use a permanent stitch. And so that's why sometimes at a year I've got to take a stitch out because it got irritated or it's poking out. But I find that there's too much relapse with facelifts, with everything, with rhinoplasties. I don't want to worry about a year or two later that a stitch pops out that I've got to manage it, especially because these are very deep. With an otoplasty, they're superficial. But other stitches, I want everything to dissolve so I don't have to mess with it down the line. I can go into talking about how I use Botox to manage the scar, how I use dermabrasion, but this is just basically a detailed video about how I do plastic surgical closures and how they differ in various parts of the face, head, and neck. I'm sure I've missed out a ton of things that I could go into detail with, but hopefully this video is an interesting one to you if you're interested in sort of how my brain works in terms of plastic surgical closures.